right, guys, we are going to go ahead and get started. It looks like things have slowed down just a little bit, but we want to make sure we have time for all of our presenters today. So we will move forward. So just again, thank you all for coming today. We're very happy to have you. We have two experts sharing their experience today with implementing the SAMHSA Promoting Integration of Primary and Behavioral Healthcare grant over the past 5 years. And also one of my colleagues who serves as a National Council Center for Mental Wellbeing faculty member will provide important updates on the Comprehensive Health Integration Framework. Next slide, please. My name is Shannon Lee, and I'm a Senior Program Manager at PCDC. Again, just super excited to be here with you all today and very much looking forward to our session. A few housekeeping items. We encourage your participation and just ask that if you have any questions throughout the session that you drop those in the chat. After our presenters share their content, we will transition into the 30-minute office hour, and there we will have time to answer any questions that you may have. And then also, just as an FYI, this session will be recorded and it will be shared with all who are attending and all those who are registered. Next slide, please. So for those of you who are not familiar with PCDC, we were founded in 1993 as a nonprofit dedicated to expanding and transforming primary care in underserved and under-resourced communities with the goal of improving health outcomes, lowering health costs, and reducing disparities. Next slide, please. So to be clear, I will read the disclaimer on this slide word for word. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, CMHS, the Substance Abuse and Mental Health Services Administration, SAMHSA, or the U.S. Department of Health and Human Services, HHS. Next slide, please. So this year, we're continuing with the theme of operationalizing integration with this webinar series. And I just want to highlight the work that we did in this space over the course of the last year. This slide shows some examples of our tip sheets. They were created, like I said, in support of last year's content. They speak to mitigating burnout through integrated healthcare, collaborative care management 101, maternal mental health from that perspective of the 30,000-foot view, and then also some ways in which you can provide equitable and responsive care to your patients and your clients. Next slide, please. And so just want to highlight our most recently posted tip sheet from the last session. This was focused on how integrated care efforts can help in addressing the maternal mental health crisis in the United States. And just as an FYI, all tip sheets can be accessed using the links that are found in the presentation slides or by visiting the Center of Excellence resource page. So again, you'll receive the recording of this presentation next week, and then you'll also receive the slide deck. So you'll have access to those links and you'll be able to access not only those previous recordings, but also the tip sheets associated with the content. Next slide, please. So before introducing our speakers, we just want to know a little bit more about you. So if you could just let us know where you work, what your primary role is, and how you would rate your current skills and comfort discussing primary and behavioral health care integration. And then if you don't see your setting or your role listed, just drop it in the chat. We just like to know where you're joining us from. And so we'll give a few seconds for that. And then just as another reminder, as our presenters wrap, we'll transition into that half-hour open office hour session. And just again, for those of you who are just joining us, the recording and today's slides will be made available next week. Okay. So it looks like we have about half and half of people who are here from primary care and behavioral health settings. We also have a few from integrated care settings as well. So just again, super excited to have you guys join us today. And if you did not see your role or your setting identified in this particular poll question, please drop it in the chat just so that we know where you're joining us from. Next slide, please. So now I just want to take a second to introduce our presenters. First, we have Tiffany Conroy, MSW, LISW. She is an integrated health consultant with the Iowa Primary Care Association. In this role, she is responsible for supporting and expanding the integration of behavioral health programs in federally qualified health centers in Iowa. Prior to this role, she worked as a trauma therapist, specializing in intergenerational trauma and survivors of violent crime. And she did this for 8 years in Chicago and the Des Moines area. Additionally, she has worked in public health and served as the Injury Prevention Program Manager for the Iowa Department of Public Health. And in this role, she led the state's prevention efforts related to intimate partner and sexual violence and violent death. Tiffany brings a trauma-informed and healing-centered approach to all of her work and believes in people's ability to heal given the right environment, inside and out. And I would also like to introduce Jennifer Robertson Hill, LMHC. She is the director, the project director for the Promoting the Integration of Primary and Behavioral Healthcare grant at the Iowa Department of Health and Human Services. Jennifer's prior experiences include facilitating treatment and therapy services at a local nonprofit that supports Iowans in addressing their behavioral health needs. Jennifer received her Bachelor of Arts degree from the University of Iowa in Iowa City, Iowa, and her Master's of Rehabilitation and Community Counseling degree from the U of I as well. And last but not least, I would like to introduce my colleague, Henrietta Croswell. She is a senior director on the Clinical and Quality Partners team at Primary Care Development Corporation. She joined PCDC in 2012 to support the unit's patient-centered medical home and practice facilitation efforts. Today, she oversees a portfolio that includes HIV and sexual and reproductive health, care management and care coordination, training, and behavioral health. She works with clients ranging from AIDS services organizations to large health systems and health departments. Prior to PCDC, Henrietta was a senior practice manager for Premier Healthcare's largest Brooklyn Health Center, dedicated to serving the intellectually and developmentally delayed population. She also supervised the adult day program at YAI. And throughout her career, she has overseen the expansion of primary care sites to include ophthalmology, gynecology, podiatry, endocrinology, and behavioral health service, and the expansion of site hours to include evenings and weekends. She also led the successful expansion and reapplication of a CDC HIV Capacity Building Assistance Center. And she has a bachelor's in psychology and a master of public health and community health education from Hunter College in New York City. So Tiffany, Jennifer, Henrietta, thank you all for being here today. I pass the baton to y'all and super excited for your content. Thank you, guys.
Great. Thank you. Shannon, can you hear me okay?
Yes, I can.
Great. Awesome. So thank you, Shannon and PCDC, for the opportunity to come and present. We're really excited to talk with you all about the PIPBHC model that we've had for the last couple of years here in Iowa. As Shannon mentioned, my name is Tiffany Conroy, and I'm an integrated health consultant at the Iowa PCA. And one component of my job here is to support this work across the FQHCs and in partnership with Jennifer at Iowa HHS. So I'm going to get us kicked off and be talking just kind of at the background level and foundational level of the development and the initial implementation of this project. And then I'll turn it over to Jennifer, who's going to be talking about the evolution of the project from the beginning to now and some of the practical application. And then we're very excited that Dr. Barry Ingebretson, who is a legend in FQHCs here in Iowa and has been a member of this project here as well, is going to speak for a few moments about his perspective on the project from the provider lens as well. So next slide, please. So just a little bit of background, PIPBHC, as we call it, it's the Promoting the Integration of Behavioral, Physical and Behavioral Healthcare. It is a SAMHSA funded grant that Iowa HHS is the funded entity for it, and then they contract down with us as well as the provider agencies that are active in the grant. It is a 5-year grant. technically, that went from 2018 to 2023. But we are actually currently in a 1-year no cost extension year. So the grant will officially end in September of 2024. And we are currently in a sustainability year right now to really figure out what components of it will we continue to be able to support and grow beyond the official funding of this project. And the overarching goal really is to improve primary and behavioral health care outcomes for individuals with substance use disorder or SUD. And so we aim to provide integrated health services to 175 clients annually and to administer 140,000 substance use pre-screenings and 130 substance use screenings. Jennifer will go into more detail on these about kind of what those services actually entail and what those screenings are here in a moment. So next slide, please. So the project is a joint partnership between substance use disorder or SUD treatment programs and FQHC's federally qualified health centers across the state. It also includes a partnership between the Iowa National Guard and a local substance use provider agency as well. And the general purpose of it is really looking at how do we provide whole person integrated care to address the substance use disorder needs and the physical health needs of the patients that we serve through that integrated care team. And the project really builds off of the progress that had been previously made through a previous SBIRT project that was implemented in some FQHCs in Iowa, as well as with the Iowa National Guard in partnership with Iowa HHS. Next slide. So this visual, I think it is a really nice way of showing the entirety of the project and how it's interconnected and who the different players are. And so up there at the top, you'll see Iowa Health and Human Services, and then the Iowa Primary Care Association. As I mentioned, Iowa HHS are the funded entity through SAMHSA, and then they contract with us. I serve as the project director here at the PCA to provide that kind of whole picture FQHC network level perspective and to provide the support to the 3 federally qualified health centers that are part of this. So there at the center, you'll see the PIPBHC model that then branches off. We have 3 FQHCs that are entities that participate in this. One is community healthcare. They are over in Davenport, the kind of Quad Cities area in eastern Iowa. We have Siouxland Community Health. They are over in the far northwest corner of the state. And then we also have Primary Healthcare, which serves the central Iowa area. And you can see there listed each of the SUD agencies in their area who they are partnered with. And then, as I mentioned, it's also a partnership with Iowa National Guard. They are physically located here in the central Iowa, Des Moines area, and they are also partnered with the Substance Use Agency as well. And underneath all of this is what we're now calling the Sustainability Advisory Committee. It was formerly PSAC, which is it was a policy advisory committee that it was PSAC originally to really look at workflows, to look at partnership agreements, to look at kind of the policy development, workflow development, and all of that. And then now, as I mentioned, we're in the no cost extension year, and we are really looking at how do we sustain both some of the actual tangible services that are provided through PIPBHC, as well as the partnership and the collaboration that has been established between the partner agencies that you see listed here. Next slide. So a couple of the unique components of our grant, one of which is it actually started a year later than other projects that were funded around the same time. So we're on a slightly different timeline. We also involve more than one partnership. So as I just mentioned, we have the 3 FQHCs and their local SUD program, as well as the Iowa National Guard. We also utilize SUD agencies and FQHCs, which is unique because a lot of the PIPBHC programs are actually a partnership between FQHCs and community mental health centers, or SAMHSAs. So that's a unique piece as well. This is also modeled off of the nurse care manager model, which is an office-based opioid treatment model. So a lot of the components and pieces of our project are similar to that model. And then in Iowa, we have some unique licensing regulations and requirements in which the ability to provide SUD services, that is licensed at the facility level versus the individual provider level. And then mental health licensure is licensed at the individual provider level. And so that can create some unique situations and challenges when somebody presents and is in need of substance use treatment. And so this project has really been able to kind of support that whole person and looking at decreasing some of those access barriers because of that partnership and the bidirectional relationship between the FQHC and their SUD service provider and the National Guard and their SUD service provider as well. So next slide. And so this is just a high level picture of the SAMHSA 6 levels of collaboration and integration. Henrietta is going to go into much deeper detail around the CHI framework and the evolution of the integration model and collaboration, but really just wanted to use this visual to kind of highlight the fact that prior to PIPBHC starting and the partnership that comes from that, we would say that a lot of the partnerships between the SUD and the FQHC, as well as even teams within those agencies, were more at that left end of this and looking at that kind of minimal collaboration or basic collaboration. And certainly throughout the project, we've seen evolution and moving this further down the line of integration, where it started kind of at that level 3. There was some basic collaboration happening on site and some co-location evolved, to moving us into level 5 and even in level 6 in terms of some shared records and electronic health and records and all of that, and really seeing an increase in the level of integration, and which is a really exciting piece, and so obviously something that we're looking to figure out how to sustain beyond this official project. Next slide. And so I'll go in just a little bit more detail in terms of what the integrated care teams look like and what the project goals are, and then turn it over to Jennifer to talk more in depth about the kind of granular level of what this has looked like. So we have the original proposal, and how it has looked is we developed this integrated care team that's made up of these different service provider types. And the purpose of it was really to take a person-centered integrated care team approach to look at that whole person health and wellness. And the population, the special population of focus is adults with substance use disorders. And then digging into that a little bit more, there were some subpopulations, which are individuals with SUD and serious mental illness, as well as individuals living with substance use disorder and those chronic physical health conditions. And so the integrated care team is made up of these different roles. At the FQHC level, we have a nurse care manager and a substance use or mental illness or mental health professional. We have a co-located peer support specialist. And then at the SUD treatment program, we also have a nurse care manager position as well as a care coordinator. Next slide. And so this is a little bit more detail into what the different parts of those roles look like. So at the FQHC, that nurse care manager is really serving people who have those co or multi-occurring conditions. So that whole person approach to look at the SUD challenges that they're facing, as well as their physical health, and how an understanding of how those different conditions impact and feed off of and feed into each other. We also at the FQHC will have that substance use or mental health professional, again, serving from that side perspective, serving the people with the co-occurring conditions, and really providing those screening, assessment, and care management to look at what are those needed services and getting folks connected to those. At the SUD treatment program, we have the nurse care manager who is integrating, again, that physical health condition into the continuum of services, which can be unique in an SUD setting, providing routine health screening, and then again, serving those clients that are a client of the treatment program, and getting this bidirectional referral process in place, where when someone is screened and has a physical health condition, making sure when they come to the SUD program that they're referred and in partnership over to the FQHC, and vice versa for both of those health conditions. And then co-located between the two is that peer support specialist. So that's a peer with lived experience who's co-located between the SUD program and the FQHC and can provide the support around both the mental health peer support as well as the substance use recovery coaching. Next slide, please. And so just a little bit more about the approach that we've taken. So the things that I'll highlight here that we haven't talked about already is really being able to look at that co-location of professionals across the different service agencies and really being able to look at how do we use that on-site physical health and care coordination at the SUD program through the hiring and training of that nurse care manager, the care coordinator, and the peer recovery specialist to really further integrate those services. And how do we make sure that there's that collaborative care happening with communication across those agencies? Because as a former provider myself, I know that you only get one part of the story or one part of the puzzle. And so having different provider types providing different services, it really allows us to get more of that whole picture of what someone's needs are, and then being able to provide that whole person approach as well. Next slide. And then looking a little bit deeper at this, really being able to look at some of those evidence-based practices like MI or motivational interviewing, looking at expert and recovery coaching, and being able to do those different screenings so that we can align the physical and mental health services and doing that coordinated approach, and then really looking at that from a policy perspective, a workflows perspective, and really doing knowledge transfer between the expertise between the two different service types, and as well as the Iowa National Guard, bringing in that ability to provide cross-training and knowledge transfer between those different entities. Next slide. And then again, a couple of things just to highlight in addition here. We really want to be figuring out how we can improve outcomes for Iowans with substance use disorders by reducing the ER visits and inpatient hospitalization. So how are we supporting them in the here and now, and also trying to do the reduction to make sure that not only from a cost of care perspective, but also making sure that people are getting services in the most appropriate and most helpful setting for the issues that they are presenting with. And then being able to increase the prevention and health promotion activities. Again, looking at that from a whole person and hopefully preventative lens. Next slide. And then the last here I'll highlight is the partnership between the Iowa National Guard and their local SUD agency, being able to provide expert and evidence-based practices to the soldiers annually, providing those medical screenings and the coordination with the care manager that's co-located between the Iowa National Guard and the SUD agency, and then looking at those mental health screenings and how are we making sure that soldiers and members of the Iowa National Guard are really getting those the entirety of their needs met with this partnership. Next slide. All right, and with that, I'm going to turn it over to my colleague Jennifer, who's going to go into more detail of how this has actually been practically applied throughout the course of our project.
Thanks, Tiffany. Can you all hear me okay? Good. So I wanted to, as Tiffany was presenting, I had the chance to think about what she was saying in each of her slides. And one of the things that I thought that I would point out is that so PIPBHC it's PIPBHC, and the previous acronym prior to the time when we started this project was actually the PBHCI. I think that's right. And these are grants that are funded out of the Center for Mental Health Services. And the first set of PBHCI grants was in 2009. And over that time period, you know, just like all of your work and our work that we're doing in this project, it has, you know, moved forward and changed. And one of the unique things about this project, as Tiffany had mentioned, was prior to our application that we submitted in 2018, these were grants that were primarily used to look at integrated care between the needs of mental health and physical health. And the first year that we applied in 2018, because we were funded a year later than when we submitted our application, it was the first year that they started to allow substance use disorder treatment programs to be that other partnership with the FQHC. So when we started this grant, we knew that, so I, as the project director, I was familiar as a mental health provider and a substance use disorder treatment professional. I knew those systems of care very well. I knew how they operated in and out, both in the private and public sector within Iowa. But FQHCs was a bit of a foreign concept. Those systems really operate completely different. Their purpose of caring for patients is different. So therefore, how they do that and in what ways is much different. And so it was really interesting to kind of just see the evolution from the start of the project and how different our partnerships talked. And that was a big benefit of having the Iowa Primary Care Association involved from the start of this project, is that we had someone who spoke that language, understood that system of care, that payer system. I understood the payer system. And so even the staff that were running this grant and implementing it, needed help with looking at integration, is kind of the point. The other thing I would just expand on a little bit is that, so this grant, as Tiffany mentioned, was started off of a screening, brief intervention, and referral grant. And so that level of integration was really just one way. It was integrating screening, brief intervention, and referral to treatment in the FQHC. So we had a SUD treatment professional who was located on site during that grant, and that was from 2012 to 2017. And when we wrote this grant application, that's really about what we wanted to do is further expand that. So we didn't want to just do the screening for substance use in the FQHC. We also wanted to be able to provide bi-directional care to patients who are either being seen solely at one of those agencies, but they have the other type of need, or people who are being served by both agencies and wanting to enhance the collaborative efforts between the staff type of professionals that serve them. So that really gets to this question of what does the patient receive? Can you go to the next slide, please? So this project expanded that effort and really allowed them to receive focused attention on the whole health of an individual. And so the integrated care teams, they meet weekly. That's one of the biggest pieces. We did have a couple of agencies throughout the last 6 years try to do that differently. And what we found was that that several hours, or even if some weeks it was only 1 hour, was really necessary to provide adequate consultation and time to work through the needs of individuals. And so that was one of the biggest, I think, lessons learned for us, is that you need to have the time for people to work together. And in our fast-paced nature of how we operate in different environments, that's not always possible, but we learned that that's essential to whole health care. Wellness activities was a part of the model that was adopted. So it was really focused on nutrition, exercise, and whole health management. So from the state level perspective, we really infiltrated a number of different efforts. You know, whole health action management is a practice that the National Council provides training on. We've done that several times. That evidence-based practice has been used at our within our partnerships, as well as at the Iowa Army National Guard, and that's expanded to the Iowa Air Guard. So that's a pretty exciting piece to us. A bit about the Iowa National Guard project is that was a part of the original ESPERT project as a special population of focus. You had to pick one, and we picked our Guard members for that original project back in 2012. That project, even without our funding, continued during that gap. And why we choose to do that is because the difficulties with managing the health of individuals who are enrolled in the Guard, because they only come twice a month to our base. But we know that they have significant issues that they need support with as well. And so one of the ways that we did that was every time prior to deployment, they have a wellness event, as well as annually they're required to participate in it. And so we implemented ESPERT as a part of either prior to deployment or during their wellness checks annually. So that's a big part of focusing on their whole health and looking at substance use as a part of that, as well as mental health, because they're required to do the mental health screenings as well. We have an incentive for the completion of follow-up. So we do, like if many of you, if you're familiar with SAMHSA grants, we do an intake data interview called NOMS, that's what it's called here. Some of you may have heard of it through GIPRA. There's different terms that are kind of used to describe it depending upon which funding source you have. But we also do follow-up. We provide an incentive because we really do value the time of the individuals that are providing us with this information. Looking at that follow-up / reassessment data helps us to look at the impacts that our services are having. So that's a super big part of our project, is valuing the time and experience of individuals that have gone through this project. One of our most significant parts of our model is our recovery peer coach. The recovery peer coaches are able to provide services at both physical locations as well as virtually, if that's something that their agency chooses to do. This is one of the pieces that has come out as being very valued by the federally qualified health centers, is that they really do value the peer type position and really want to continue that after our project. Recovery support services, this is done largely in the Center for Substance Abuse Treatment grants, the federal discretionary grants, really focusing on how do you help support someone's recovery. There's really important pieces to that that are not just, clinically speaking. It's an evidence-based practice. This isn't something that I have seen a lot in our Center for Mental Health Services discretionary grants. So that was kind of a new concept in working with CMHS on that. Our probably most significant recovery support service that we provide is gas cards to support people in accessing treatment. And this really helps to overcome barriers. There is a lot of research out there. If you haven't done a lot of research on recovery support services and your integrated healthcare efforts, I strongly encourage you to do so. But there's a lot of research out there that supports the importance of bringing these in to your integrated health efforts. Next slide. So part of the enrollment process, as I mentioned, is the evaluation piece that you see there in the second part. And then we also perform screenings. There is physical health indicators that are required to be collected by SAMHSA. And then a part of our application also wanted to, again, establish that whole health approach. And so we do have a number of mental health screenings. So all of our clients that are admitted into the program receive physical health indicator screening as well as the mental health screening. And of course, their eligibility is for the grant is based on substance use disorder diagnosis. So that information is collected as well. Next slide. So we had developed a brochure, and the brochure is something that I think has been used in different variations and probably more frequently in the beginning. But PIPBHC is a grant, obviously, that is kind of introduced into the infrastructure of these different systems of care. And people don't really always understand what grants are or what they look like or how does that benefit you. And so we developed a brochure that helped to emphasize some of the services that were available through this. Just because if you're a person who's coming into care for your physical health at the FQHC, or if you're going to the SUD treatment program, you think you're going there for one thing or for one reason, and that can be a lot of different things depending upon the individual. So they don't always know what types of services are available to them, and it obviously varies depending upon which environment you're in. So that brochure and listing that out really helped to provide some information to the person coming in about what was available to them as a part of their grant participation. Next slide. As I mentioned, recovery support services are very helpful in navigating any sort of challenges that they encounter. One of the biggest pieces for the research that supports recovery support services is the engagement in the recovery process. If you aren't able to help people meet their basic needs, they're going to have a really hard time focusing on one of the probably most challenging parts of their life that they will ever encounter. So substance use disorders are incredibly difficult. It takes a lot to get somebody to that first place in their life where they're ready to address those needs as it relates to their substance use. And so anything that we can do to help to remove barriers and help them understand that because it's very difficult in the very beginning of recovery to imagine that life can be better than what it is. And recovery support services really help to do that. If you know somebody can help you ensure that your child is safe while you get care, you're more likely to come back. If you know that, like recovery peer coaching, if you know that there's somebody else there who's been there and done that and has a better life now, that gives you so much hope. And supplemental needs are kind of an umbrella category that focuses on things like clothing and hygiene, making sure that people have the ability to wash their body and their hair. And it's difficult to want to show up. I wash my hair like once every 5 days. And if I miss like that 5th day and I don't want to show up the next day to wherever I have to go, especially not in person. So, that's making it a little bit funny, but it is serious, is that if people don't feel clean, they don't want to go places. Like, these are really important basic needs that we need to help people access. And so clothing and hygiene is one of them. It can help get clothes for, a job interview. Other supplemental needs are like wellness, like gym memberships. Obviously, a whole person care really tries to focus on meeting the needs of the whole person. Recovery support services are one of the best ways to do that. Next slide. You can go to the next slide too. I already mentioned a few of these things. Some of the most successful pieces, like I mentioned, are those weekly team meetings. We provide annual site visits. I lead those, and that really helps us to give one-on-one time. We do monthly provider calls, as it's mentioned there in the 3rd bullet, but those are really just kind of check-ins and identifying the status and updates of where everybody's at with their project implementation. But the annual site visits give one-on-one time between the state, the IPCA joins us, and then we're able to really talk about what are the particular barriers. That's probably on my challenge slide, I'm sure. But one of the biggest difficulties with this project is probably the size of it. Most PIPBHC grants are usually between one partnership. And so by having it with oversight from the state, we were able to do 3 partnerships plus the Iowa National Guard project. But I wouldn't say that it's very simple work to do. And when you're trying to work between 2 programs, it does help to have somebody with oversight to help them communicate and identify how to meet in the space between their systems. Data collection, as I mentioned, we look monthly at what evidence-based practices our PIPBHC-funded staff are training. We use the majority of our funds to pay for staff out of this grant. And so looking at how they're being trained, what they're being trained in is really helpful. We look at the number of services that are provided, as well as ER inpatient hospitalization, admission, and discharge information. Quarterly, we collect integrated healthcare services, so that really looks at health promotion and wellness, identifying what are the different types. That waxed and waned probably throughout the last 6 years of the project. Sometimes the partnerships are doing that more. And then sometimes when we struggle with staffing or the capacity or holidays, I noticed that there's kind of a decrease in the health promotion or the integrated healthcare services that they provide. We also collect prevention, recovery support service information, wellness and health promotion type details as well when they are being provided. And then we also look annually at the outcomes and impacts on physical health. That is collected through the physical health indicator data that's required by SAMHSA. And so we're able to look at that and see about the time of intake as well as the time of follow-up, how our physical health being impacted in the services they're receiving. Can you go to the next slide? Strengths, strong evidence to support bidirectional integration. That's definitely there. There is so many positive things that have come from this project, and it's different depending upon which partnership you're looking at. One of the things that we look at with our sustainability work is that, we're not just looking at the sustainability efforts at our state, but also between the partnership as well as within the organization. So we look at things like sustainable practices, like recovery coaching, sustainable policies, like how do you ensure that recovery coaching becomes a part of your program and stays a part of your program, as well as obviously funding. That's what sustainability usually means to many people, but we look at it from a variety of perspectives, because sometimes it takes time before you can build a sustainability funding mechanism for things. The alignment, so the department I work for would underneath an alignment between public health and human services, and mental health was housed in human services, and substance use services were housed in public health. So that's been very helpful at aligning the efforts between those two state entities as a part of this project. There's definitely leadership and legislative support that we've accessed. As a state employee, I can't legally lobby for anything. So I've been able to kind of lean on the PCA to help me understand things that maybe I wouldn't have otherwise understood, and they're doing legislative work. So I understand from the FQHCs what's going on in that world as well. And that's very helpful to our FQHCs involved in the partnership. The project's been really well received by the partners. Everybody is really on board with this work and they see the need for it because they work with the clients every day. And it's very far and few between that they meet a client that doesn't have more than one major whole health concern. So it's definitely a needed service. Next slide. Challenges and opportunity. So as I mentioned, integrated care is really complex, and it's defined differently depending upon who you're talking to. So how they see integrated care, what that means, the lengths of integrated care that they want to go to, that's also a big piece too. Like as a state employee, providing oversight, I'm working individually with these organizations and partnerships because maybe the organizations within both partnerships feel differently about or think differently about how they will address integrated care or provide integrated care. And so sometimes it's looking at it between the partnerships, but then also obviously SUD treatment programs, all these agencies are operating independently. So even SUD treatment programs may be looking at how they provide integrated care differently than the next one. So it's very dependent upon the environment specifically, where their readiness is, what they're ready to do, what they're capable of doing. A big part of integrated care is understanding that it is complex. And one of the more challenging pieces that we have heard about a lot is just that these agencies between the partnerships, they operate differently when it comes to electronic health records, and they don't communicate. So that's not going to be fixed with one grant. So that's one of the challenges. How much time do I have left, Shannon? Yeah.
I think you're good on time. I think you have one
Okay.
additional slide. Yeah, you're
okay. So one of the difficulties that we've also found is like when we look at when we look at services, how do you sustain those? SUD agencies in Iowa, the way that they are ran, they have multiple funding streams, but they usually are running on a fee-for-service model, whereas FQHCs are running on is that prospective payment system, Tiffany? Yeah, that's what I thought, but there's lots of acronyms today, and I'm speaking in front of a bunch of people, so, that puts pressure. And so what that means is, like, for instance, with like Expert is a service that is reimbursable through Medicaid, but because it's an additional service and FQHCs are paid on a per member per month prospective payment system, that brings difficulties to adding something else because they're not going to necessarily be paid for it. Did I say that right, Tiffany? Okay, essentially. So that's one of the largest difficulties is the SUD treatment agencies and FQHCs are paid differently and they're funded differently. So that's one of the difficulties you have to kind of work through. Then of course, COVID, I don't really need to say a whole lot about that other than that. One of the major ways that COVID impacted us is that most physical health indicator data was collected in person and during COVID and for a significant amount of time afterwards, physical health you weren't always able to get physical health indicator data because you weren't seeing the people in person. And then even for a long time after that, it was about what is the immediate need of seeing somebody in person, and not always the physical health indicator data from a grant that we were required to collect. So that is difficult in terms of being able to gather data and then speak to the outcomes of how physical health is impacted by grant services, because we don't have the data to do that. So that's been a difficult piece for us as well. Opportunities. There are a lot of opportunities in integrated care. We're always looking for additional ways. This is going to be a long-term process in terms of, and how it'll be shaped really depends upon leadership support within the partnership agencies as well as the organizations themselves. Some, things will be able to be sustained relationships, perhaps some of the physicians beyond the grant funding, but we will have to continue to work at this as a state entity. We have to all work together to figure out how we can continue to further integrated care in Iowa. The Iowa PCA does a behavioral health echo. I'm sure most of you are familiar with what echoes are, but that is an opportunity from a sustainability standpoint as well to continue sustaining the education and knowledge gained through these projects, as well as the providers themselves that do the work.
Okay, it sounds like Jennifer's audio may have just cut out.
Can you hear me?
Yeah, okay, we can hear you now. I think you cut out for
Okay,
just a
sorry.
minute. So
the whole Zoom just shut down. I was like, that's weird, and then it popped back up.
okay.
So the Integrated Provider Network in Iowa is a network of substance use disorder treatment agencies that were competitively procured through the state to provide substance use disorder services through the Substance Use Block Grant. And so that's an organized effort of further integrating care through the work that we do. So continuing, like I said, it needs to be a state initiative as well as being done in the communities. Next slide. So Pivot's late implementation, we started a year later than everyone. We also were the only, at the time that the funding was awarded through SAMHSA, we were the only partnership that was doing integrated efforts between FTD treatment programs and FQHC. So we didn't really have anybody to model after or talk to about the work that we were doing because it was new. Partnership development, some of the agencies between 2017 and by the time this grant really got up and running in 2019, even though these agencies had been involved in partnership efforts before, there was turnover in the staff, there was turnover in leadership. Having buy-in was something that we had to really develop because it wasn't just established. And then of course, COVID, like I mentioned, that was a significant impact in our in-person services. Next slide. Or is that the last one?
Yeah, so I don't know, Dr. E, if you are there and able to come off mute. Dr. Barry Ingebretson is attending the webinar. As I mentioned, he's been a provider and really instrumental in all of this work and FQHCs in general. So he was just going to speak for just a couple minutes about the changes that he's seen this have and just from a provider perspective.
Okay, can you hear me all right?
We can. You're good to go, Dr. E.
Okay, so I just want to take a couple minutes to highlight what I think is one of the real successes of the PIPBHC program. I'm going to speak mostly in terms of the data about what we have from our site in Des Moines, but I think this has been replicated in the other two sites as well. As you know, the whole purpose from what you've heard of PIPBHC is to try to integrate medical care, substance abuse, mental health care, so you have a total picture. And one of the things we discovered really early on was that we had picked up a couple of hepatitis C patients with screening, and we began to kind of focus on that. And so I just want to present a little data, which I think is really quite remarkable in the sense that we're dealing with a high-risk population of difficult to treat and reach patients. And over the past 5 years in Des Moines, we have found 22 patients with untreated hepatitis C. some others that were positive but had been previously treated. This is out of a population of about 258 total patients seen in the program, which, doing the math, is a prevalence of about 10%, which compares with the US general population prevalence of 0.01%. So obviously, we were finding an awful lot of hepatitis C, and it was untreated hepatitis C. Most of the 22 did not know they were infected. 2 of them had been previously diagnosed and cured. 2 of them knew they were positive but had not received care. The outcome of the 22 was probably less than we would hope for. We had 7 that went through treatment for hepatitis C with our own providers or somewhere else and were cured. We have 2 who are currently under treatment, one of whom is actually under treatment with one of our partner PIPBHC programs in Davenport, which has been kind of a nice handoff. And she is now getting her treatment over there. So this is very good news. The bad news is that 14 of the patients that we have referred to treatment either did not follow up or started the process and did not actually begin their treatment. We're now in the process of trying to relocate and re-engaging those patients in treatment. That's been very difficult. Some simply refuse, for example, because they say they feel fine, despite all the education that we can provide to them. Some are concerned about insurance issues, even though we can help them with insurance issues. But most simply can't be located to be re-engaged in care. So what I'd like to point out is that hepatitis C is now a treatable condition with a short duration of treatment. It is expensive, but most of the time you can get folks covered for that treatment. This is really low-hanging fruit. I guess that's what I'm trying to emphasize. No matter what your level of integration, if you start working to look for hepatitis C and refer them to a reliable treatment source, you can make a huge impact with this disease. The long-term complications of liver cirrhosis, liver failure, organ transplantation can be avoided with the treatment. The cost of treatment is coming down, though it is expensive, but we can usually get folks in Iowa covered with Medicaid because of the ACA Medicaid expansion a few years ago. And it's theoretically possible that the cost of diagnosing and treat these patients will be totally covered by the savings from the long-term complications if they go untreated. Relaxing some of the treatment requirements in Iowa has also made treatment easier for patients and clinicians alike. So I guess I'd just like to emphasize again that no matter what your level of integration, you can look for hepatitis C. It's a simple screening test, a blood test. And even if you don't have a close relationship with a medical provider, perhaps that's a way you can start integration, is by finding a medical provider that can get these folks into treatment. Obviously, it should be someone, for most of us, I think, that work a lot with Medicaid, the uninsured, and have ways of getting folks into treatment. Just a quick message. Here's something that integration can really do. It can be relatively simple. It can be a way to start integration between your organizations, even if you're not ready for any kind of full-time integration. That's all I have quickly.
Awesome. Thank you. Thank you so much, Dr. E. For those of you who have questions, please drop those either in the chat or in the Q&A, and we will now transition to Henrietta and her piece. Thank you.
Thank you, everyone. I'm happy to be here to talk about the CHI model. If we can go to the next slide, please. So my goal is just to kind of give a bit of a background of the CHI bidirectional approach, as well as an overview of the CHI model, and also talk a little bit about the Learning Collaborative. Next slide. So I think we've already heard, and was mentioned by, I believe, Jennifer just a few moments ago, the value of having bidirectional integration and how critical that is. One of the things that we want to always take note of is that when we talk about bidirectional integration, we're really looking at how behavioral health into primary care and vice versa has an impact on the health of the individuals that we serve. So when we look at primary care services, for example, we see high rates of physical illnesses amongst individuals with mental health illnesses, as well as high costs. Sometimes we see that there are access limitations when it comes to physical health services. And when we look at mental health and substance use into primary care, we also look at some common conditions that we may see, such as diabetes, heart condition, heart disease, asthma, depression. And we also are seeing anxiety, ADHD, behavioral health problems in children, and really looking at opportunities if there are ways in terms of prevention and early intervention. Next slide, please. So why do we need this framework? And why do we need this right now? As we already mentioned, we have many individuals that are hitting our system that have many co-occurring physical and behavioral health issues and concerns, as well as social determinants of health needs that needs to be addressed. As you see noted here, we have high costs that are impacting poor health outcomes. We are also looking at the continual inequities as we see as it relates to structural racism, looking at economic challenges across all the settings that we work in. And we understand that it will benefit us if we are looking at a system where we can look at evidence-based integration as an intervention to be able to best engage all the settings that we're working in. So with that, we want to make sure that, if we are doing and utilizing this framework, is that enough? And we understand that there has been progress, but, uptake still remains limited in all of these areas. Next slide, please. And why are there still limitations? I think, we heard today and some of the things that we've seen as we talked about this model and this framework is that policy and implementation barriers remains a challenge for a lot of us. We look at the lack of flexibility as it relates to integrating certain services. And the challenges really looks at implementation. What are some of the implementation challenges that we're seeing in a lot of these settings and why there is no uptake when it comes to that? We also see that there's a lack of integratedness, and I'll talk a little bit about that in a moment. And looking at how is physical and behavioral health services are operating in particular settings, or if they are siloed, how are there better ways to be able to best integrate that? And then when we talk about the bidirectional aspects of integratedness, how are we measuring that, and what does that look like? And there still is a lack of appropriate measures to be able to do that. And then when we look at financing, there still are limitations when it comes to how are we supporting the implementation and sustainability when it comes to financing, integratedness, and what are some of those pieces that we have in place. So with that said, next slide, please. We look at the CHI framework, and as you can see here, we have a very interactive model that you see here on the slide here. But this slide really demonstrates the interconnectedness of looking at patient-centered care and their role in regards to the community, as well as looking at physical, mental health, and social well-being of that individual. And if you look at the bottom, you see that there are other non-factors or non-health factors that really support some of these particular areas. So we want to take a look at, as we look at the individual, we're not only looking at the individual from a health perspective, but there are also other non-health perspectives that we want to look at. So when we look at the CHI model, we're really looking at a framework to provide support and guidance as it relates to implementing the integration of both physical and behavioral health. And this is a way to be able to help providers and payers and other individuals that are part of that system to be able to do a number of different things. One, to be able to figure out a way of how we can really measure the progress and facilitate the improvement of really organizing the delivery of integrated services. Second, we want to be able to really demonstrate the value that is being produced and how we are progressing in the integrated service delivery system. And then thirdly, we really want to be able to provide really a way to really initiate and sustain financing as it relates to an integrated service delivery system. And when we talk about integratedness, as we had mentioned, as part of the 6 steps of integration with SAMHSA, the last piece of integration, we're really looking at the degree in which programs and practices are organized to deliver integrated physical and behavioral health, prevention, and treatment services to individuals or populations, as well as being able to address social determinants of health. And this is also a way to be able to measure both of those structures, whether it's staffing and care processes, to be able to support to the extent of integrated services into physical and behavioral settings. So with that said, we want to be able to really utilize that opportunity to look at how is really integration working within your respective settings. Next slide, please. What you see here is just another way in terms of how we've been able to expand the CHI model. We also utilize the general health integration framework to help support that was related to the behavioral health organization. As well as there was a specific study that was done in New York State that really looks at the integration framework from the perspective of working with small primary care practices. So this kind of really provides kind of like the background to be able to support the CHI model. Next slide, please. So when we look at the characteristics of the CHI model, there are a number of areas that we really can look at to really provide a consistent overview of what that model looks like. One is that the framework really provides a broad application to both the physical and behavioral health settings, as well as in adolescents, adults, children, populations. So one of the things that we want to make sure is that, you know, this framework can be applied to those particular settings. Secondly, we want to make sure that there are evidence-based domains as it relates to integration and really looking at measurable standards for that integration. We also have a self-assessment tool that is also part of this framework. And then we also look at the flexibility of really being able to achieve progress when we talk about integration. There's also looking at the connection of progress as it relates to integration. And we look at this through metrics in terms of how we apply metrics to be able to demonstrate the value of integration within this particular model. And then lastly, we also look at how payment methods are ways to be able to improve the value of really, and also sustaining the integration of this framework as well. Next slide, please. So when we talk about the CHR model, there are specific components of this framework. These particular components really gives you a good insight in terms of not only the extent of the framework, but also a really good deep dive of what those components are. Because we're short on time, we won't be able to get into the specifics, but these are just kind of like the main components of the CHI framework. There are 8 domains really focusing on specific care processes that I will go over in the next slide in a moment, but it really addresses the physical and behavioral health in a really integrated way. Secondly, we also have 3 specific stages of the integration, of the stages of integration. And those stages of integration really looks at from a level of 1 all the way up to 3. And that level really kind of rates the practice in terms of where they are as it relates to integration. That integration also will connect to the 8 domains that provides a little bit of an overview in terms of where the practices are as it relates to those particular 8 domains, as well as those 3 stages. Fourth, we also look at the integration of metrics. So when we talk about metrics, we want to be able to take a look at to what degree of integration is actually happening within your particular setting. And then looking at ways to be able to improve the integration at each of those particular stages and levels. And then fourth, we really look at the payment methods, really looking at, okay, what has been the history of how you're covering costs when it comes to implementing and sustaining integration? How does that look like? What value are you putting into your integration process within your particular setting? So this framework really covers these four main components as it relates to integration. Next slide, please. As I stated, these are the 8 main domains of integration. And again, these 8 domains really highlights the connectedness with the 3 stages that I mentioned. So first, we really look at the screening and referral and follow-up process as it relates within your particular setting. There are different levels in which practices and settings will be able to kind of rate themselves in terms of where they are. So it will really take a team effort to really assess in terms of where you are within these 8 domains. The second domain really looks at your prevention and treatment of common conditions. And there are specific examples in which we give in this particular framework that provides guidance to the practices and other settings as well. We look at the continuum of care management. What are your care management efforts? What does that look like? We also look at self-management support. Is there support? Are there limitations? Are you working with other practices or other organizations within your community? What does your teamwork efforts look like? Is this still siloed? Are you working with physical and other behavioral health, staff? And what are some of the challenges or steps to take to make that better? And then we're also looking at systemic measurement and quality improvement efforts to be able to support, this other level of integration. In addition, as we stated earlier, to be able to address physical and behavioral health challenges, we always have to look at the community and social services. What is the support that you are getting from your immediate community? What does your linkage opportunities look like? And then lastly, how do we sustain these efforts for the long term? How do we make sure that this becomes pretty much a fabric of what you do within your organization? Next slide, please. So I'm gonna just wrap up in regards to just talking about a current learning collaborative. So again, as part of the CHI framework, we made some revisions to this particular framework. And now we're in a process where we have embarked on a project, which is a learning collaborative project with 2 states. This particular project is going to be, has started, and it's a 7-month learning collaborative project. We have the pleasure of working with 2 states, Texas and Kansas. And within each of those states, we have the opportunity to be working with representatives from the state, as well as community clinics and organizations that represents the respective states, as well as behavioral health and public health and physical health organizations. The goals that we're hoping to achieve with this particular learning collaborative is multifold. One is that we definitely want to ensure that the CHI model and framework is tested out by these organizations. We had a very extensive process in terms of orientation, and we started the learning sessions over the last couple of weeks. So some of the main goals that you see noted here is definitely to be able to scale the CHI framework amongst the state and behavioral health and primary care provider organizations. Definitely being able to test out the framework as a self-assessment tool. And then we are offering specific tailored and consulting and technical assistance support to the organizations. This is also an opportunity for these organizations to work collaboratively together to be able to communicate, develop processes, be able to form relationships and partnerships within their state, and to be able to work in a way that they can be able to improve integration within their respective settings. Each of the organizations were also provided a stipend to support their participation and their time. This is just one of the efforts in a way to be able to test out this particular framework. Next slide, please. So as I close, one of the things that you all can definitely consider are a few things. As we heard from my colleagues, the wonderful program that they have outlined, one of the things that you can think about as well for your team and your organization is, what are some of the supports that you need within your organization? What does that look like? How does integration look like? What are some of the efforts that you all are taking right now or additional support that you would need? And then hopefully you'll be able to decide and outline what those necessary steps could look like. With that said, I thank you for your time. I know that this overview was brief, but happy to share any other information. So I'll pass it over to my colleague, Shannon.
Thank you, Henrietta, and thank you, Tiffany and Jennifer. We appreciate you all so much. I know we are a little bit over on our time for the session, but we just felt that this content was so important for you all to hear. If you could, before we move into our office hour, to please just answer the question that's showing on your screen, our post-presentation poll. And if you have any questions, please feel free to drop those in the Q&A or the chat. We didn't get a ton of questions, but we do have a few for our presenters, so we'll make sure that we go over those in just a second. And I believe some resources have been shared in the chat, so just take a look at those. Some of your other colleagues and attendees have dropped some resources as well. Jennifer and Tiffany have both done that. So if we can just go to the next slide. We will get into our questions. I'm going to start with one that we received. I believe, Jennifer, you answered this in your presentation, but still want to make sure that it's asked and answered in this forum. The first is, what is the relevance of having the National Guard involved?
Well, so the Iowa National Guard project started, so our Iowa National Guard has mental health staff, and they have obviously physical health care staff as well, but they didn't have any SUD treatment staff. But we know that there's a high occurrence of substance use in our Guard members, specifically alcohol and cannabis. So back in 2012, that was one of the requirements of that SBIRT grant, was that you had to have a special population, and so the Guard was chosen at that point. That was chosen. It's very difficult to fund, kind of additional services such as substance use screening at the Guard, just because it's just the way that environment is created. And so it was something that one of our agencies had continued to do after SBIRT, all on their own and funding that staff. And so we felt like it was a great addition to the PIPBHC staff in particular. And also continuing to focus on the health of our Guard members.
Awesome. Thank you, Jennifer. Next question. How could group behavioral health private practices assist or partner in this project for sustainability? Behavioral health providers and group practices could provide SUD or co-occurring services, and also they're able to take Medicaid and Medicaid HMOs.
So, I mean, I think, Dr. E talked a little bit about how just, adding in a physical health screening is an example of furthering integration. And I would say, in our PIPBHC project, we implemented a number of mental health screenings. One was the PTSD tool, which focused on screening for trauma in the primary care environment. And then we also have the GAD-7 that focused on generalized anxiety. They did do ACEs as their screening, looking at childhood trauma, and then or adverse life experiences, not necessarily childhood trauma. And then they also did the PHQ-9, which focused on depressive screening. And so that was one way that we furthered kind of the mental health aspect. I think that adding screenings is definitely one way that private practice and group practices can improve. It isn't. One of the other things we did with the knowledge transfer trainings also was we educated individuals on things like, as a provider, like I remember you know, when I was just doing substance use disorder treatment before I, you know, worked towards my expertise with mental health, I didn't know a whole lot about physical health conditions, let alone the ones that are commonly seen in people who have substance use disorders. And by the knowledge that I've gained since then, makes me much more aware of what questions I need to ask and understanding how I can help, even if I can't physically obviously treat somebody because that's not in my scope. I know the resources that I can access. I know where I can go to get help for that. And that's a big part of what we do when we're helping people, is just figuring out where they can get the help too. So.
Yeah, the one thing that I'll co-sign all of that and would just add on, I think a lot of people just don't even know that FQHCs exist, or what they are, or who they serve, or how they serve folks. And so I would say familiarizing yourself, you know, with, if you're in Iowa, you know, the Iowa PCA website has our impact report that talks about all of the different health centers that are out there, what populations that they primarily serve, the count, you know, the area, the regions, and all of that. Whichever state you're in, your local PCA would have that information as well. And really figuring out who points of contact are there, and building relationships. So there can be that opportunity, if you are doing, as Jennifer had said, to start asking about, even if you're not necessarily fully screening for physical health conditions, because as we have learned, and through this project, but also just as providers, that personal connection can go a very, very long way. If you were to say, hey, I know Jennifer over at, you know, insert name, federally qualified health center next door. I'd really like to help you get connected with services there, can really make a difference for how someone might want to or feel comfortable accessing those. So that would just be one thing. And just familiarize yourself with what your local FQHCs are, and then building those relationships is really important.
And I'd add to on there, kind of with what you're saying, is that also being familiar with what you know, Medicaid does pay in your state. For example, like I mentioned, ESPR is a reimbursable practice on Medicaid, and how that is done is different in each state. So that's just one example of, like, ESPR is, you know, so in Iowa in particular, it's considered an early intervention service, and we don't license that. So it's not required to have a SUD license to provide ESPR. But it's just understanding kind of the full continuum of care for substance use and mental health, and kind of where your practice can continue to expand into those spaces. And then you can identify if it's reimbursable or not. Because that's one of the things that we work on. That's why we do federal discretionary grants at the state, is identifying best practices, and, you know, how do we implement them and help fund them until we can come up with reimbursable mechanisms. So for, like, example, recovery coaching was not something that was always approved as a fundable service through Medicaid. And then Iowa it now is, as a result of our Access to Recovery grant that we did for like over 10 years. So it took a long time. And it's still not, you know, utilized a ton, but we're continuing to grow the workforce, because, like many things, new ways of doing things take multiple things happening at once. So you can have it be a reimbursable service through Medicaid, but if you don't have the workforce in your state, then it's not going to really take off either, or it'll be available in silos.
Thank you both for answering that. Our next question. Jennifer, this is for you, and Tiffany, please join in. Can you share more specifically what services or benefits SUD clients have access to as a result of these integrated partnerships? Are they able to start medications for opioid use disorder treatment the same day? Or perhaps they have access to behavioral health counseling without having to stay on a wait list? Do the downstream resources exist to ensure continuity of care following screening? So that's a lot, and I can repeat any that you need me to.
Yeah, so to answer your first question, that was one of the goals of the project, was to ensure that individuals who needed access to care, that the team was able to provide a very, not just like a regular warm handoff, like I'm going to help you call somebody, but also like I know so-and-so, they're going to be here on Tuesday, or we can set you up an appointment right now. So it kind of created trying to minimize any sort of challenges for the people that are coming into one environment, but they need something else. So like the FQHCs, the care coordinator would be there so many days a week. And also at the FUD treatment program, that's probably one of the challenges, is like finding the right amount of time and days, like actual, like real life stuff of when staff should be somewhere, because it always, you can't please everyone, and that people have certain needs, and scheduling needs is a big, challenge. But so that was one of the things, is so decreasing, the likelihood that they would have to jump through hoops, I guess, basically, to get their needs met. And to answer your question specifically about MOUD, over the last 6 years, that was definitely one of the things that's changed a lot. So in the original, in 2018, when we started, only one of the FQHCs was providing MOUD care. And since that time, I think now all three are. And so that's one of the things that's kind of changed, is before, the FQHCs have to rely on the substance use disorder treatment programs for care like MOUD. And now they're not only, still obviously providing that along with the clinical services that are found in SUD treatment programs, but the FQHCs are also providing on-site MOUD care as well. Did that answer? Was there a third one? I think there was a third one.
It was, do the downstream resources exist to ensure continuity of care following screening?
So that's one of the places I would say that limitations exist, is because you don't share an EHR between the two programs. That's one of the things I think that has to be kind of worked out, is that, one of our programs, primary health care and community family and resources, that's one of the partnerships that are in Des Moines. Like I mentioned, SBIRT was not something that was required that you carry a license for, but they went the extra step of adding primary healthcare locations on site to their SUD license, so that they could provide outpatient and assessments for SUD on site at primary healthcare locations. That's been difficult to staff, so that's been a challenge, but they're at that step of, how do you give someone access? Can you give someone access to your EHR? And that's really a legal question that I won't answer because I'm not a lawyer, but and that probably varies too upon the individual environments and situations, how you do that. But I would say that data piece, the way that we have done it is I put that website in there for PIPBHC. We've created grant documentation that allows for the sharing of information on the specific grant requirement pieces. So like the physical health indicator data that I mentioned. So the information is shared in integrated care team meetings after intake, as well as reassessment. And then we continue as a state entity to provide kind of like an assessment as whole, to share some of the data that we identify through we have an evaluation team that does that work. And then we share it back out with our providers as well on a state level perspective.
Okay.
The one thing that I would add to that, Shannon, too, from the mental health counseling or therapy piece of it, is our behavioral health directors at each of the FQHCs are active participants in the PIPBHC teams and attend the monthly meetings. And so each of the FQHCs look really different in terms of what their behavioral health team looks like. But, we do have one of our health centers that has the behavioral health consultant model. And so, let's say somebody comes into the SUD agency and they are referred over to the FQHC for a physical health appointment. There can be an actual warm handoff during that physical health appointment to a behavioral health consultant to come in and provide that point of care and potential for long-term therapy services. So yes, the behavioral health piece of it is also a component of it, the mental health services. And they also, again, it looks really different at each health center, but it is an opportunity to give people either point of care at that time without a wait. We also can do same day appointments for physical and behavioral health appointments and all of that. So it is included in the model.
Okay. Thank you for saying that. Next question, any suggestions or advice as to how to increase or improve communication between providers? And this person is speaking as a mental health provider in a larger FQHC.
I think just from my experience, when I was a provider, I worked in a rural area, but I don't know that mattered so much, but trying to get communication going with physical health primary care providers was difficult. Like at most I could get, you know, a release of information and then send a letter letting them know that someone was in, you know, my care for substance use or mental health. But that's not really like collaborative. It's more of like a notification. And so like for true collaborative efforts, you have to have either in person. I mean, I think the in-person meetings work best. I know that the providers have tried to do some virtual stuff, especially during COVID. And their feedback to me was just that the in-person communications led to better collaborative efforts, just having time to sit down together and talk. And they didn't just talk about specific patients, but they would see patterns and they would be like, hey, have you seen this? Or one of the partnerships saw, you know, significant issues with like food, getting, you know, in the rural part of Iowa, they had access with getting to the food bank when the food bank was open, because the food bank wasn't open like all the time. And so then they were able to work together to come up with, you know, between the FQHC and the STD treatment program, what can we do to address that as a need? So they were able to see patterns or lack of resources or resources that each other didn't know about. So I would say the collaborative efforts, both individually as well as like across system care, is really done great in person, but we know that that's not always possible, but that's just our experience this time.
Thank you. And I believe we have time for one more question. Tiffany, this question is for you. And the question is asking if you all have been mostly successful with completing GPRAs. If so, what has contributed to that success? And then also, if you could tell us what GPRAs are, that was also asked in the chat.
Tiffany, you want me to take that?
Yeah, go for it, Jennifer, and then I can add on. Yep.
Okay.
Yeah. So GPRAs stand for the Government Performance as Results Act. And the GPRA is a legislative congressional act that was established, I believe, in 1990, and that required centers, or SAMHSA basically, and their centers, Center for Mental Health Services and the Center for Substance Abuse Treatment, to collect data information on their grant and funding opportunities that they put out. So CMHS refers to that as the National Outcome Measures, or NOMs. And CSAT uses the term GPRA when they're talking about data interviews. So depending upon which grant or funding opportunity you're talking about, it sounds different, but it's the same thing. They have different tools, so there's different questions on the data interview tools, but they're a lot of the same questions, and it's just really data collection that looks at individual client participation. And in terms of successful, for the most part, most of our grants, discretionary grants that do the GPRA or NOMS data collection, because there is outcome requirements. I believe both CMHS and CSAT require you have an 80%. So that's probably what you're talking about when you're talking about successful with completing it. For the most part, we range between like 70 and 90% for the completion of our GPRAs. In terms of success, we have a pretty comprehensive process that we work with all of our organizations on, how to do that and how to manage that. We do just a variety of different strategies, and I'd be happy to talk about that individually. I can put my email in there too if somebody wants to set up a separate call. It's kind of a lot to explain in a minute. So
Thank you for the Cliff Notes. We appreciate it.
Yeah.
And then Tiffany, did you have anything that you wanted to add? Okay. So Kimmy, if you could advance us to the next slide. Just briefly want to share some upcoming events that the National Council has. If you want to check out on the 15th, there's an Equity in Action session, and then also on the 29th, a session on pediatric integration. Next slide. And then also just want to highlight this ECHO opportunity supporting youth in rural settings. The application deadline is Friday, February 2nd, which, believe it or not, is in a couple of days. So if this is something that interests you, please check it out. There is a link here. You may not have the slide deck by Friday, so just check out the National Council for Mental Wellbeing's website, the Center of Excellence, if this is something that you're interested in and want to make that application deadline. Next slide. And then this is my contact information. If you have any questions, please let us know. Jennifer dropped her email in the chat. Henrietta, if you could do the same thing in case anyone has any questions about the CHI framework, please feel free to reach out to our presenters or to me, letting us know if you have any questions. As we wrap up, I just encourage you to please take our evaluation survey. It's really helpful for us as we plan our content for the remainder of this year. We have a couple of more webinars that we're working on. They are in development, but always want your feedback and just let us know how everything went today. So again, we thank you. Thanks for making it to the finish line with us. We are at 2:30. So again, just reach out if you have any questions and have a great day.